Okay, it's my pleasure to moderate this very interesting webinar by the International League Against Epilepsy from the Eastern Mediterranean and African Epilepsy Educational Webinar about a very interesting topic. The topic will be the implementation of epilepsy surgery in resource-limited setting. Dr. Nico Insulin from South Africa, he's going to be presenting a wonderful talk about it. And we have a very interesting panels, Professor Graham Fegan from South Africa and Dr. Ahmed Najar from Saudi Arabia. They will be also share us the discussion. Professor Graham Fegan is a well-known pediatric neurosurgeon and epilepsy surgeon worldwide. A few things about him. He studied medicine at the University of Cape Town, where he had his mentorship by Warwick Biakok. He's a very famous surgeon, stimulated his interest. He did internship in Groot Shore Hospital, and then he completed the neuroscience master in London. He spent 2 years for some reason in Canada, in a very cold area in Manitoba. And then he went back to Cape Town, where he did neurosurgery training in 1992. He's trained in pediatric neurosurgery by a very famous, well-known surgeon, neurosurgeon, Jonathan Peter, and he also ran a very busy center of neurosurgery at the Red Cross War Memorial Children's Hospital for more than 10 years. Dr. Graham also, he's a clinical, besides his being a clinical and research interest in functional and pediatric neurosurgery, he's also a general neurosurgeon. He shared and organized and been a president for many famous conferences, the Continental Association of African Neurosurgeon Society in 2012 and 2016. In 2018, he was the president for the International Society of the Pediatric Neurosurgery. And for 3 years, he's the president of the Neurosurgeon of South Africa. And we are lucky to know and announce that he's going to be the president for the World Federation of Neurosurgery for next year, which will be held in Cape Town. And I hope that many people will be able to join since COVID-19 is hopefully it's over. The second panelist will be my colleague, Dr. Ahmed Najar. He's a graduate from King Abdulaziz University from Jeddah. And then he joined Taiba University in Medina, where he joined as a teaching assistant. And then he went to Canada particularly for University of Montreal in Montreal, and he did his neurosurgery residency. Dr. Najar, then he did 2 years of functional neurosurgery and epilepsy in Toronto, in Canada. And then he came back less than a year or 2 years back to Medina, where he was originally worked there. And he's been working as a neurosurgeon, and he still is doing everything in neurosurgery, but he has a great interest again in functional and epilepsy surgery. Epilepsy is a very important topic, and this is a good paper came in neurology talking about the models of community-based primary care of epilepsy in low and middle-income countries by Dr. Singh and his group. And this is a good an example of research that can be done in these countries. You know, when you say about low and mid-income countries, it's a World Bank classification of countries depending on the nation's per capita gross national income. So if you say low income, it means it's less than 4,000 US dollar, and if it's mid or low mid countries, income is less than 12,000 US dollar. The burden in a low and mid income countries, it's huge for the neurosurgeon. And this paper came from Journal of Neurosurgery, and Professor Graham Fegan is one of the co-author of this interesting paper. And it shows in yellow and red how the burden of a neurosurgeon per population. These are heavily populated countries with low resources and have very few neurosurgeons. So you can imagine one single neurosurgeon, how many population he has to serve compared to other countries. Dr. Nico Insulin, he's just wrapping up his case, and he should be join us shortly if he's not already joined us. I'm gonna present him as I got. This is I mean, he's a qualified physiotherapist, and then he saw the light of neurosurgery. He started in medicine, and he got his interest in neurology, like most of us enjoy the neuroscience as a science. And then he pursued his career in neurosurgery. He was specialized at the University of Cape Town, completed neurosurgical training, obtained many fellowships in functional neurosurgery in various types of Europe's centers. Then he completed the fellowship of pediatric neurosurgery at the Red Cross Children's Hospital in Cape Town, and he's currently a consultant neurosurgeon, particularly pediatric neurosurgeon. He has special interest in functional neurosurgery, epilepsy surgery, spasticity surgery, and movement disorder surgery. So I hope he's already now with us, so we can have the microphone, and he take the video camera for his presentation.
Thank you very much. Good evening, everyone. I apologize to the organizers that I tested your adrenal glands tonight. I'm still busy. I'm still in theater. Forgive the bit of a background that you'll see movement still, but I hope that the sound isn't too bad. Thank you for the great honor, and thank you so much for inviting me again to talk with the ILAE group. I think it's such an incredible platform, and I'm so grateful for the opportunity to speak to this specific audience tonight again. Just before I start and I give my talk, I just want to tell everyone about another venture that we part of in the ILAE. The ILAE has established a surgical epilepsy surgery surgeon sort of education workforce, and that's something that we've currently sent out. Some of you might have filled out some of the survey monkey survey questions that we've asked and we've sent out as well, and thank you so much if you did. But that's going to allow us to, over time, improve the access that people have to epilepsy surgery training specifically, and we hope that with time we'll be able to just improve the access that we all have to be taught in epilepsy surgery. So keep an eye on this space. So hopefully in the next few months, we'll be able to start publishing some of the data that we've gotten from there, and we'll then use that specifically to try and formulate an international surgical education strategy that more and more people can benefit from, and that in the end our patients can all benefit from all over the world. And specifically for us in sort of developing countries and lower middle income countries, we don't always have access to the fancy big places. I think I just quickly want to share my screen. There we go. And as I said, excuse the noise in the background. It will definitely quieten down very soon as well. Sorry again that I'm keeping everyone so late. Good. So thank you so much for the introduction. I'm a neurosurgeon based in Cape Town at Red Cross Children's Hospital. And I'd like to share some of our thoughts with you. We're fortunate in the unit that we have this rich history of functional neurosurgery since basically 1980 already. And I've been in a privileged situation to be one of the sort of followers of people who has preceded me. Professor Fegan, that's on the call as well tonight, and Professor Jonathan Peter before him, and Warwick Peacock before him. And we're very fortunate that we were able to establish functional neurosurgery in the Children's Hospital very early on. And it's something that just flourishes from year to year. In the past few years, we were able to really broaden the epilepsy surgery practice as well. And I'd love to share some of my ideas with you, and then definitely reflect on a lot of the audience members as well have published quite a lot of papers on this topic, sort of starting an epilepsy surgery service in a resource limited setting over the past few years. So I'd love to reflect some of that ideas with you. And then I think it would be a rich discussion that we can have during and afterwards. So please, for the panelists, please feel free to interrupt me at any time if there's any specific question and you see I'm sort of moving on to the next topic. Please stop me there. I think important that we just start with the basics. Is what is epilepsy surgery? I think epilepsy surgery involves neurosurgical procedure when an area of the brain is involved that is involved in seizures is resected, ablated or disconnected or stimulated with neuromodulation. The goal is to eliminate the seizure or significantly reduce the seizure burden, and in the end, improve the patient's function and their quality of life. And this is a Wikipedia definition, but I think it's very appropriate. So we know that epilepsy surgery is divided into three big categories. One is resection surgery, where we can take out a part of the brain that is abnormal. The second will be disconnection, where if we can't, for any reason, take out that part of the brain, we disconnect it and isolate it to a certain part of the brain. That part will then still continue having seizures, but it won't propagate to the rest of the brain. So clinically, we often don't recognize it, and it prevents propagation and spreading or secondary generalization in seizures as well. And then the final category is neuromodulation. This is also the more expensive category. The fortunate thing and the important thing to remember is that neuromodulation is palliation only. As soon as you cannot resect or disconnect the epilepsy focus in the patient with epilepsy, with refractory epilepsy, neuromodulation is there to reduce the seizure burden, but it's definitely not curative. As soon as you stop the stimulation, epilepsy is back, but often you can reduce the frequency and the severity and the number of epileptic events that the patient has with one of the modulatory techniques. So the one we commonly know is vagal nerve stimulation, but also recently RNS is coming into the forefront, and deep brain stimulation as well for epilepsy. Epilepsy surgery is not tumor surgery. So I'd like to make the case that the tumor surgeon should not be the person who leads your epilepsy surgery program, especially when you set it up. There's just a different mindset, a different way of approaching epilepsy surgery that tumor surgeons are often taught not to do, and for good reason. They need to get rid of a tumor or a malignancy or a benign lesion, specifically an area in the brain. But important to remember that with epilepsy surgery, we're not working with a specific small lesion or a spot on the brain or a big spot on the brain. We're working with a network, and that's important to remember, that you always will have a lesion or an abnormal part of the brain where there's high frequency desynchronizations or synchronous epileptic activity that happens. That then spreads with the propagation of other networks to another part of the brain. There's also part of that, some of the networks that aren't involved, that might not be part of this epilepsy spread. And it's important that if we just resect a lesion, we will often miss the epileptogenic zone around it. And we definitely will not interrupt the epileptogenic network or the network where the propagation will take place. And therefore, it's not tumor surgery. You should not just remove the lesion. That is not the emphasis or the idea in epilepsy surgery. It's all about this. It's about understanding and developing hypotheses of which parts of the brain are involved in this abnormal electrical network, where the seizure generator zone is, where it spreads to, and then secondarily, where does it propagate? How does generalization happen, as an example? And if I just resect the small lesion, I miss the whole big problem. And we know that in excess of 60% of cases, if you just resect the small lesion without at least boundaries or thinking about the network, you will still have epilepsy thereafter. So just to continue this thought line of mine, Why is it not just tumor surgery? Well, I think from a technical aspect, epilepsy surgery, we are much more kinder to the brain in general. You don't sacrifice brain unnecessarily. So subpial planes of dissection is important. We usually will preserve veins and arteries, whereas in tumor surgery, you do need to take the vascular supply to the vessel, to the tumor, but you definitely need to look after the veins as well. But it's this subpial technique that lends itself to functional neurosurgery epilepsy surgery that is not always practiced in tumor surgery, except in the world of low-grade gliomas. There, it has been definitely embraced by low-grade glioma surgeons as a technique as well, the subpial technique, preserving a peel bank so that you don't injure vessels that supplies a specific part of brain. We resect areas. We don't resect lesions. So I resect an area of the brain that's abnormally involved with epilepsy. If there happens to be a lesion in that area, then let it be that. If there happens to be dysplasia in that area, then that is so. We'll take that out. But we don't specifically target a lesion only. That should never be the case when you do epilepsy surgery. Function matters a lot. And we should always balance the tissue that we resect versus what are we going to sacrifice if we do sacrifice a part of that part of the brain. So one should never just resect the epileptogenic zone and not think about what you're going to sacrifice. You don't want this double loser scenario where a patient after the operation still has epilepsy and now they're hemiplegic as well, or they're blind, or they can't speak permanently. And that's important. That would be the worst scenario ever. And that should be never events in neurosurgery, especially in functional neurosurgery. We want to make sure that we resect the epilepsy zone to give the best chance of the patient being free of seizures, but function does matter. We do sometimes do these big operations where we even resect half of the brain. Definitely you sacrifice some function there, but all of the function comes back except fine hand function and a homonymous hemianopia that the patient will retain after a functional hemispherotomy or a hemispherectomy. For example, for hemimegalencephaly or Rasmussen's encephalitis would be the types of indications that we would do hemispherectomies for. But there we want to do it as early as possible, and we rejoice in the plasticity of the brain that helps us regain function. But it's planned sacrifices of function. It's never haphazard and, oh goodness, you've lost something. We need to know whenever we sacrifice function, why, where it is, what the implication for the patient is going to be, and what the chances of it coming back. And that comes into heavily in your discussion with consent with the family before an operation and every single day after the operation as well. There is often some of the abnormal tissue left behind. I think if you do map function, you will sometimes need to leave some dysplastic cortical tissue behind. You often will leave a small area of a ganglioglioma of the temporal lobe that protrudes through the temporal stem into the basal ganglia area. That part of the ganglioglioma needs to stay behind. It's not a malignant tumor, and the goal is not tumor surgery. The goal is to disconnect the temporal lobe where the seizure focus is. And definitely, you should watch that ganglioglioma that it doesn't grow as the patient grows older and over time. But it's not uncommon to leave a small bit of tumor behind or dysplastic tumor behind. We are only after the epilepsy focus and the network that we want to interrupt. But it is important to remember that the extent of resection does matter. Study after study does show that if I leave dysplastic temporal lobe behind, so if I just resect the anterior 4 centimeters of the temporal lobe with the anterior temporal lobectomy for significant type 2 cortical dysplasia, and I leave that dysplastic, that flare signal area that's abnormal in the posterior temporal lobe behind, we know that our chance of seizures recurring is very high. And it's often that you need to go back as the patient grows older, or if you can do an awake craniotomy to map for speech function, to take the resection as far back as function allows you, because that residual dysplastic area and are involved with epileptic activity very commonly. So extent of resection does matter. So I don't mean to say that you just take out what you plan and leave lesion. You always need to balance it. That's the important part. Function does matter. And this just illustrates this point again. I think this is the last 2 slides about this topic. But what the ideal scenario would be is that if we have the actual seizure onset zone, and we have an area that we've identified on interictal telemetry, maybe with invasive monitoring, that is a potential seizure onset zone as well, we need to resect both. Then the patient will be seizure-free after surgery. However, if we have a scenario where we have an actual seizure onset zone, and we have identified where the potential seizure onset zone is, and we resect only the potential seizure onset zone and leave some of the actual seizure onset zone behind, this patient won't be free of seizures afterwards. And the same way, if you resect only the actual seizure onset zone, but you leave the potential seizure onset zone that is part of that abnormal network behind, the patient will probably still have seizures after surgery. And this just shows this concept of it's not tumor surgery. You need to think about electricity and networks with epilepsy surgery. And the whole workup is based on that point. Forgive me, I know this doesn't project very well, but again, multiple studies have shown that it does not mean if you have a lesion in a specific part of the brain that you can see, that by resecting that, you're going to treat the epilepsy. It's not uncommon to have an irritative zone, for instance, in the medial temporal lobe, but you have an epileptogenic lesion on an MRI scan, a seizure onset zone in the patient around that area. You have an irritative zone around it, and then eloquent cortex that you need to be careful of, and a symptomatic area. So the patient complains of this part being affected when there is seizures. So the semiology points to that area. And here again, you have a functional deficit zone. So on PET scan, if you're lucky enough to have that, you have hypermetabolism in this area. This patient will only be seizure-free if we resect the whole abnormal area, preserving eloquent cortex. And yes, we always need to think about medial temporal lobe problems in all patients. It's not common, but also not too infrequent that we will do, for instance, a frontal lobectomy and a temporal lobectomy in the same patient. But that is why widespread adoption of stereotactic EEG placement have become so popular all over the world. But it's not something that one should start off with doing. I think in resource-limited settings, setting up a program, I don't think one should aim to evaluate the whole brain, form a very good hypothesis as to where the epilepsy is, and then work up that area as good as possible. It's not a problem, I think, to do a frontal lobectomy, treat the seizures, and then at a later stage, if you see that there is still some temporal lobe epilepsy, to then do a separate operation in a second sitting, as an example. But be open to the concept. It's not tumor surgery. Where there's an abnormality, it does not mean that is what you need to resect. We need to always think wider with epilepsy surgery. And I cannot emphasize that enough. So why should we look at epilepsy surgery in low and middle income countries? Well, epilepsy is very common. It's the most common neurological disorder affecting people of all ages and classes, all different economies, all different people around the world. It's interesting that the prevalence of epilepsy differs between developed and developing countries. The problem is that developing countries have a higher prevalence in both urban and rural settings of epilepsy. And that's important for us to remember. The remainder of approximately 50 million people worldwide will suffer from epilepsy. 80% of them will reside in developing countries. The remainder of these, 40 million people, are unable to obtain appropriate treatment, and as a result experience significant morbidity owing to seizures. Yet it is treatable. Often epilepsy is curable. Remember, there's only 2 ways that epilepsy can be cured. One is if you're one of the rare lucky individuals that have misfortune of neonatal epilepsy, but you outgrow it, then it's gone. The only other way that other patients can be cured from epilepsy is surgery. Medication does not cure epilepsy, and that's important for us to remember. Furthermore, these patients in developing countries still face the psychosocial implications and the stigma and prejudice due to stereotypes and negative attitudes towards epilepsy. And it's especially rife and prominent in developing countries. People are incredibly prone to stereotyping patients with epilepsy. Witchcraft and concepts like that are still very common in developing countries. It's important globally. There's about estimated to be 5 million people diagnosed with epilepsy each year. And as I said, a big proportion of these people are in low and middle income countries. There's about 4,600,000 people today in low and middle income countries that has epilepsy. A third of these cases will be refractory to medication. So that means there's at least 1.8, I can't remember if I did the math somewhere, but about 1.8 to 1.9 million people in developing countries that needs epilepsy surgery. They are refractory to medication. Yet where are they? We don't see them. They don't come. They don't get referred often enough. And we need to talk about that as well today. It's important to remember that epilepsy is not a benign disease. People die from epilepsy. There's a lot of comorbidities associated. 56% of patients fail to report all their seizures. More than 86% of all the seizures occur at night time, so are not self-reported. If you don't do telemetry at night, you're not going to catch them. We know that a third of patients with epilepsy will be refractory to medication. Excuse me. If you have seizure freedom on your first drug and you're one of that lucky 50%, that's good news. But we know as soon as you need to add a second, third, or a 17th drug, the rate of treatment, your seizure freedom just rapidly declines. So if you're not controlled on 2 drugs, you are refractory. And that is what the epilepsy definition states as well. Just to show you that each drug that you add does not really add significantly to the overall seizure freedom of patients. It's well recognized that there's all these comorbidities with epilepsy, and it really affects the life and livelihood, quality of life of patients on a daily basis. There's an 8 times higher mortality rate, 8 times higher risk of premature death for patients with epilepsy, whether that's from SUDEP, whether it's from status epilepsy, cardiac problems, suicide, or accidents when they fall. But 8 times higher, that's incredible. And that's definitely significant. So there should be no question that us in resource limiting settings, low and middle income countries, need to evaluate and promote epilepsy surgery. But it needs to be done safely, and we should not do third world surgery. It should be first world surgery, but with third world or developing country workup maybe, and to a great extent. We don't have the fancy things like MEG and PET often everywhere, but we'll talk a bit about what are the other things that you can do. Most of those cases, that 1.9 million cases, is not lesion free or MRI clean negative patients that needs all these wonderful tricks that we do as epilepsy surgeons. The biggest proportion in Africa, as an example, will be lesional epilepsy. Patients that had TB, patients that had neurocysticercosis, that still in Africa is the most common cause of adult onset epilepsy. That should be treatable, curable. So when to operate? Well, we operate when there is refractory epilepsy. So when the patient does not respond to medication, and I'll tell you now, show you now what the definition is. For lesional epilepsy, definitely, I think in all over the world, if there's a specific lesion and you can allocate or focus during your workup that the seizure originates from that area, the semiology of the patient, what happens to them during the epilepsy correlates with that, and your clinical and electrical, the EEG evaluation correlates. If there's a lesion that causes epilepsy, I think you should really consider that patient for epilepsy surgery, even if they are controlled on medication. We need to remember that medication often has side effects. Medication costs a lot, and in resource limiting settings, if you need to start adding second and third drugs to it, I think that patient should definitely be a candidate for epilepsy surgery. And then, yes, there's certain conditions where it doesn't even matter whether the patient should be on medication or not. the patient should have a specific operation. And the classical example is patients with Rasmussen's encephalitis or patients with hemimegalencephaly. These two MRI scans at the bottom are good examples of that. These patients need a hemispherotomy or hemispherectomy. Their epilepsy can be cured. The epilepsy will never be controlled with medication alone. So epilepsy surgery should be prominent early on in them. This is coincidentally some of the more difficult procedures. I think these are the types of cases that needs to be referred to experienced centers. But like I say, the biggest bulk of epilepsy work, I think, can be done by well-trained functional neurosurgeons that are trained in the basics of epilepsy surgery, and we'll talk about that. So if you are still having epilepsy and you're already on 2 agents that you are taking, so you're using the medication and it's prescribed by a neurologist with epilepsy experience, so we know that it's the correct medication for the type of epilepsy, and the patient do not have good epilepsy control. And remember, seizure control is not 1 seizure per day or only once a week or once a month. It's no seizures. Yes, we can argue about the maybe once a year seizure patient. But remember, 86% of all seizures occur at night when the patient do not know about it. So it's often not reported. So we cannot say that they don't have seizures unless you've monitored them with long-term telemetry as well. So there's no time duration of the medication anymore. Since 2017, with the ILAE definition statement, it's only 2 drugs that's not effective, it's used, and it's the appropriate drugs. There's no time limit. I think one has to be reasonable. It doesn't mean that 2 months after the starting it, if you're not at the correct doses yet, you just operate. But don't wait for 2 years. Don't wait for 17 years or 25 years like we're seeing currently. If the patient doesn't respond after appropriate few months, definitely do a workup for surgery. And this is the goal. We want to correlate the anatomy of a lesion. So where do we see something on the scan? And what do we see clinically in the patient? So the semiology, what happens during that epilepsy seizure? And then we need to always do an electrical evaluation, an EEG, whether that's invasive or just scalp EEG initially. If all 3 of those components point to the same region of the brain, then your chance is very good of having seizure freedom after surgery. And that is what we need to know. The goals of epilepsy surgery are these 3 points. We then need to know, good, so I must resect this. Should I or can I? So is it eloquent brain? Is it part of a network? Does the epilepsy spread away from that? So is there a wider area that I need to resect? And the third question is, do I have the technical ability to safely perform that resection? If the answer to that all is yes, then definitely you should do epilepsy surgery. If the answer to these 3 questions, eloquence, network, if the answer is I don't know about the network and I might not have the technical skills to do it, please don't not allow the patient to be referred somewhere where there can be epilepsy surgery performed. That's so important. So what are the questions that you need to ask yourself, I think, when you're setting up a center? Firstly, can you as a surgeon do these operations? Have you visited centers? Have you learned the tricks? Have you learned the way of thinking? Are you able to change your general neurosurgical technique to the point where you are now able to offer these highly specialized, not difficult, but specialized techniques for patients with epilepsy? Do you have a neurologist? Is it the best plan for the neurologist that you have currently, or do you need someone else to come and join the practice? Does the neurologist that works with you in the hospital that you have, do they have the ability to visit areas that practice epilepsy surgery? Because in general, there is a lot of fear among neurologists to refer patients for epilepsy surgery. I think often, I hope it's not true, but I think from a surgeon's point of view, we often think that the neurologist sort of thinks we're just going to be rough and orthopedic, like lob out a part of the brain. That's not true. Epilepsy surgeons are just as interested and as caring about the patient and their outcome, their function, as you as the neurologist are. And that's incredibly important to remember. If your neurosurgeon does not have that mentality, then he's not the person that should be doing the epilepsy surgery for you in the unit. So the neurologist needs to know, is this the best plan for this patient? So what are the criteria for surgery? Is the epilepsy definitely refractory? Have I treated with the correct medication? And what is the benefits of early surgery? We know that earlier operations is better. The network doesn't form. Children especially do very well after epilepsy surgery. You can often sacrifice some function in children that you couldn't in adults because children just regain that function so well due to plasticity. Do you have a neurophysiologist? You have to, and you need to ask the question the neurophysiologists need to ask, can they help delineate the focus? So where does the epilepsy start off? And what is the network? Remember, I told you that it doesn't just start, epilepsy doesn't start somewhere only. We need to know it starts somewhere. Is that truly the place where it starts? And where does it spread to then? What is the network? And that's where electrical evaluation of the EEG is mandated. I don't think one should ever do epilepsy surgery without an EEG. It doesn't need to be stereo EEG, but definitely at least scalp EEG and consider subdural or more invasive EEGs before it. Do you have an intensive care unit or a high care unit where these patients can go to? One should not operate on patients if they're just going to die afterwards because of sepsis or because of poor blood pressure control. Then your unit should not be doing it. So there needs to be very good care of in a high care unit or epilepsy unit where the team that looks after patients can be careful and look after your patients and their well-being. Parents always need to ask, do I trust this team and what can I do to help? We always need to remember that everyone that I mentioned on this list is part of the same team. All refractory epilepsy cases should be fair game for epilepsy surgery. It doesn't mean you're going to operate on them. It doesn't mean that they all need the same operation. Very rarely do two patients need the same operation, but they all should be in this group where we are evaluating them for surgery. And that's an important place to start. Lesional epilepsies, as I mentioned, I think if there's a lesion and the patient has epilepsy and you can attribute the epilepsy or the electrical abnormality to that lesion, that lesional area should be removed. These patients are potentially curable if it's safe to resect that lesion. If there's clear laterality, if you know that the epilepsy is definitely coming from the one side, then they are good candidates for epilepsy surgery. Remember, we're looking at starting up a practice. So this is not what we would do necessarily in our unit or what would happen in Toronto or what would happen at these big units all over the world. But in general, initially, don't start operating on patients where there's equivocal status, whether the temporal lobe on the right or the temporal lobe on the left, both might be the cause of epilepsy. Do not end up in that Scoville sort of situation where you've resected both temporal lobes. Never do that. 100% we must make sure first where the epilepsy is lateralized. And if you don't know that with basic investigations, the patient should be referred to a tertiary quaternary center where those deeper investigations can be done. We need to evaluate the focal network. If there's focal epilepsy to the frontal lobe or to the temporal lobe only, good candidates to start off with. And then is there secondary generalization? So always ask yourself, well, I don't have a specific focus that I can see on my scans, but I have a patient with drop attacks. Remember, corpus colostomy are amazing. In our scenario in Africa, there should not be patients with epilepsy and drop attacks that comes into our burns wards anymore. Yet they do. Patients should not be walking around with helmets because they have drop attacks. These patients are very good candidates for corpus colostomies. So those patients should be the ones that you look at in the early days as well. Always, I think the smaller indications, you should be careful about developmental abnormalities in terms of sort of genetic problems, dysmorphic problems, patients with stroke early on, perinatal strokes. There's often a disturbed network. The vascular supply is different. It's often more difficult patients to do epilepsy surgery on. Traumatic cases, if it's focal epilepsy again, and you can localize it to the injury area, and you can be safe that you can resect that area safely, then yes, even traumatic epilepsy might be an indication, but be careful of them because it's often more diffuse. The genetic syndromes, I think these patients need a lot of workup for surgery, and those aren't the sort of early on types of operations. And definitely the same with non-lesional. I think in the early times of setting up a epilepsy surgery service, if there's not a specific abnormality seen on the scan, on the MRI scan at least, I don't think one should do the surgery. We do often, but it's a lot of invasive workup that goes into those patients, so they should probably be referred. And then syndromic, well, again, you can sometimes consider a corpus colostomy in some of the Lennox-Gastaut type of patients syndromes, but in general, syndromic epilepsies also need a lot more workup in general. So what is the team that you need to set up around yourself? Well, there needs to be a neurologist with a special interest in epilepsy, someone that understands surgery, and someone that understands the role of surgery in epilepsy. Shouldn't just be scared of surgery. There needs to be a neurophysiologist. There needs to be someone that can do telemetry. You need to have EEG. A once-off EEG, I don't think is good enough in most patients for epilepsy surgery. We can talk about examples maybe that differs. There needs to be an intensive care team, a good high care team. You need to have a social worker or a psychiatrist, a neuropsychologist, ideally, someone that can walk this road with the patient, evaluate them before surgery, evaluate them after surgery, make sure to exclude underlying psychiatric comorbidities. These patients often do not do as well afterwards, and you can sometimes propagate or worsen their psychiatric comorbidities. So be very careful of undiagnosed personality disorders and psychiatric conditions. It's worthwhile investing in getting psychiatrists and neuropsychologists involved in working up these patients pre-operative already. And then there needs to be a neurosurgeon, as I mentioned, with the interest in this and with the skill set that we're talking about. Every epilepsy patient should be a surgical candidate. Everyone that is refractory should be evaluated for surgery. Important, it doesn't mean they're going to get operation, but they should at least be considered. Unless patients are not refractory and they don't, in a resource limiting sort of building up a segment early time in your practice time, most patients should have a lesion. And definitely never do epilepsy surgery if the family refuses. It's not, functional neurosurgery is not that type of thing where you get court orders and you operate on children because their parents refuse and family members refuse. Don't. You have to spend time to convince the family, but to discuss all the options with them. They should know what you know about epilepsy surgery by the time you've finished speaking to a patient before you do any epilepsy surgery procedure on their child or their family member. Don't force people into this ever. So they need to know what the risks are, and they need to appreciate it. Both the parents, the surgeon, the neurologist, and the neurophysiologist, the psychiatrist, and your whole team needs to understand all that goes on. So what are the prerequisites for you've now decided this patient needs to be worked up? Definitely a detailed clinical history and examination gives us a lot of information. The semiology, what happens when you have the epilepsy, is so important. That often localizes the epilepsy already. And you need to spend a lot of time in developing that skills, getting your neurology team up to help you in that. Don't just do it one person at a time. Imaging, this can be one of the things that we can discuss as well. I do think MRI scan is really needed for epilepsy surgery, unless on a CT scan you have a clear abnormal lesion and your EEG workup indicates to that area as well. I think one should be careful about doing epilepsy surgery without having an MRI available on patients, but I'll show you an example and we can discuss it around that. You have to have EEG. You should not do epilepsy surgery just on a hunch of this is the area where the seizure starts. It has to be worked up electrically. Surgical techniques we can discuss maybe at a later stage, but one has to be familiar with this safe subpeel technique, preserving all the vessels, keeping peer between you and the brainstem with the temporal lobe. Never, ever, ever, ever should it happen that you damage the sylvian vessels or that you damage the brainstem during epilepsy surgery. Then you haven't followed the rules. The rule is always keep peer between you and the vessels, and you and the brainstem. And that's a basic, simple technique. It also preserves a lot of blood. You don't bleed as much if you do a subpeel resection technique. Good imaging is important, ideally MRI, but as I say, we can discuss now about whether you'll just do it with a CT scan. Post-operative care should be adequate for patients. You have to have a monitoring facility. You have to be able to do telemetry. You have to be able to do longer-term EEGs. One shot 10-minute EEGs are not good enough to start operating on a patient. They need to be able to do overnight EEGs at least. There needs to be the ability to deal with the complications. If you do cause a vascular injury, you need to have someone in your unit that can help you to manage it. If there's not someone, then you should not be doing this. If you cannot treat the hydrocephalus that might ensue after doing a corpus callosotomy, you should not be doing the corpus callosotomy. It should not be that patients die because no one could deal with complications of the surgery. If there's no one on duty after hours and your patient gets a subdural or extradural bleed after taking out the temporal lobe and dies, it's completely negligent. Then you should not be doing epilepsy surgery. Gross total resection matters. Remember, we said you need to still try and resect as much as you can. And that subpeel technique is so important. It's not a haphazard process. It should not be just a single visit where you make a decision to start operating on a patient. It needs to be multiple times. There's no room for paternalists. You need to be open. You need to listen to the parents, to the neurologist, to the psychologist, the psychiatrist, to the neurophysiologist. Thorough investigations is important, and there needs to be good post-op care. We cannot emphasize that enough. If the above is not possible, you should not do epilepsy surgery in your units. So with regards to imaging, I do think it's important that if you don't have MRI scan, you really need to be careful before embarking on the epilepsy surgery program. There needs to at least be an MRI available in the country where you practice, so that the patients that you operate at least has had an MRI before surgery. It just is important that you can just see subtle problems so much better on the MRI. You can evaluate the eloquent area better. I don't think you need necessarily PET scan in a resource limiting setting. Same with Syscom or SPECT scans or MEGs, definitely not. But an MRI scan, it should be a very important investment in the country where epilepsy surgery is started. Always remember, don't underestimate ultrasound. Every hospital in the world will have a gynae department, and every place where there's people delivering, there will be an ultrasound. Learn how to use an ultrasound. These are pictures of, you can clearly see the cortical dysplasia in this specific gyrus. There's a sulcus and there's a sulcus. So we need to resect this whole gyrus here. That's the abnormal part. And you can do it. It's real-time navigation. You can find the lesion, resect it, and make sure that you've resected it all during it. So ultrasound is fantastic. On a CT scan, yes, for a case like this, where you do see a focal abnormality, if the semiology and the EEG telemetry does point to that same area, probably this case, you can consider operating without having MRI scan. But I don't think subtle dysplasias and lesions like that, it should ever be possible to do it without. In your theater, basic neurosurgical theater, bigger space is always better, but there needs to be space. You need to be able to wake your patient up during the operation and have enough space around the patient to move, for the anesthetist to be able to evaluate the patient, for the neurologist to be able to evaluate function while you are mapping the brain. There needs to be enough space, but it doesn't need to be these multi-million-dollar, big, massive theater spaces as well. You don't need any fancy equipment. The ultrasound, as I said, a microscope definitely does help, but the good magnification with loops often can help you a lot. In the early days, do not invest in electrocorticography. We can discuss that, but that should not be one of your early investments. Invest in your telemetry room. Invest in getting an MRI scan. You have to have space where you can video record the patient while they're having overnight EEGs, so that you can combine semiology and your telemetry and your clinical evaluation, and then combine it with your MRI to have, again, an anatomy, clinical, and an electrical correlation. And then you decide what part of the brain you resect or disconnect. Patients has to go to an intensive care or high care unit afterwards. Do not let patients die because you just had to leave them in a general ward. Often patients with invasive grids, subdural grids, can die in units if they go somewhere where there's not neurosurgical care close by. So be careful of having patients get grids and then going away from neurosurgical care to another hospital or another area where they get evaluated for telemetry. Try to keep everything in-house. It's incredibly important. They do die when there's not neurosurgeons that take care of that acute situation early on. Pathology service, yeah, I think it helps, but it's definitely not a deal breaker. You can always make an arrangement with pathologists in other areas or other countries. It's very interesting to have pathology after your resection, but the proof is in the pudding. The proof is whether the patient still has epilepsy afterwards or not. So it's not a deal breaker if there's not a very experienced pathologist in your area. Don't ever forget the ultrasound. Don't forget that. You just get these beautiful pictures, and you can often do wonderful resections with that. Invest in at least some form of a cortical stimulator. I have as example of an Ogerman stimulator here. It's they don't make them anymore, so it's very cheap. If you can find one, you can really get it fixed by the local engineer in your hospital or the electronics expert in town. And waking up a patient and stimulating for functional areas of the brain is the gold standard. PET scan and functional MRI scans are not the gold standard to determine eloquence. So being able to wake patients up during surgery, having an anesthetist that's comfortable with that, invest in that, because that's going to allow you to do bigger and bigger procedures much more safely. You have to be able to map. We don't only map for big areas like speech and where the hand moves. We want to do subcortical mapping as well. And this, to do this, you ideally need to be able to have one of these stimulators. Monopolar stimulator works very well for subcortical stimulation. Remember, if you only have a monopolar stimulation, you do cortical mapping with the anode, the positive, and as soon as you go subcortical to map for white matter tracts in an awake patient, you change over to the cathode. You do subcortical stimulation with the cathode, the negative. So it's important to remember that these equipment are incredibly expensive, but I'll show you this. Every hospital that has an anesthetist has a basic nerve stimulator. With this nerve stimulator, you can set the frequency to low frequency, and you can use it as a monopolar stimulator. And you can do exactly what we can do with that expensive stimulator, but you just connect the monopolar probe to this side, and you put the little ECG dot somewhere else on the patient's head, and you have a monopolar stimulator. You can stimulate between 2 and 5 milliamps, which is exactly what we do with the expensive stimulators as well. So always remember, there's a way fast to get all these very expensive equipment. Invest in small things that can help you a lot. So in terms of just a few examples of what type of cases I think one should start off with, definitely focus on the temporal lobe problems. Get to know temporal lobe anatomy, temporal lobe surgery early on, and invest in those patients. There should not be patients with refractory temporal lobe epilepsy in your hospital after the first 2 years that you've been doing this. You really need to invest in these patients. Clearly, this patient has mesial temporal lobe sclerosis. There's abnormality on the right temporal lobe. So doing anterior temporal lobectomy in the beginning and progress it to more selective abicular hipocampectomies for adults. As you get more experience, you can do that as well. But just standard anterior temporal lobectomies and then taking out the hippocampus in total works incredibly well. There's no need to be fancy and do selective abicular hipocampectomies in the early days of your setting up a practice. Patients with ganglioglahoma, so medial temporal lobe ganglioglahoma, this patient is ideally suited if the epilepsy comes from that area with your semiology and with your EEG you've confirmed. This patient needs a temporal lobectomy, do a standard anterior temporal lobectomy, resect the lesion, and then do the hippocampectomy as well in that same patient. 80% of these patients will be cured. That means Engel 1 after surgery, no more medication. And that's important. These patients are all very good examples. If your EEG points to temporal lobe pathology in the same patient, you have to do a temporal lobectomy for them. Drop attack patients, remember, if the patient typically have atonic seizures, they are very good candidates to do colostomies. It's a general type of epilepsy operation that is used for many other tumor surgeries, a transcallosal approach. So if you're comfortable with that, use it. Get to know the anatomy and learn how to do these anterior 2/3 colostomies for drop attack patients. They should not be in your hospital anymore. You can see just a colostomy makes a massive difference for patients after colostomy. I've shown you this as an example. Not all cases are simple. We often have these cases where the patient will have a right frontal lobe lesion, probably from previous TB or cavernoma, but she had a right occipital AVM as a small child that bled and sort of burnt out as well. But the EEG points towards the temporal area. The semiology points towards the temporal area. We go ahead in a patient like this, and this patient needs a lot more further investigations. So we placed subdural grids for her. We evaluate that frontal cortex, we evaluate the temporal lobe, and we evaluate the occipital area over that lesion, the occipital AVM lesion that you could see. I placed depth electrodes for her as well across that area. And in the end, the frontal lobe was completely normal, but I had to do a complete temporal lobectomy and a neocorticectomy over this part of the parietal lobe, over the angular gyrus as well in the patient. And she's thankfully seizure free, and we're a year down the line already. So this is what she looks like. There's my EEG placement. This is where the epilepsy was marked in red. The frontal area was completely normal. And this is then the post-op image, the temporal lobectomy and the neocorticectomy of that area where my depth electrode was placed as well. But that is not the type of patient that you should start out with. So from examples from all around the world, some very good literature published on exactly what we're talking about today, about starting up an epilepsy service. In Indonesia, there's articles published in 2021 as well, where they developed this program from nothing. They started doing epilepsy surgery, and they divided it into two groups. From 1999 to 2004, they just did temporal lobe epilepsy with lesions. They did psychiatric and psychology evaluation, scalp EEG, and they got MRI on all their patients, but they did no invasive monitoring. And then the second period after 2005, where they then evolved and they incorporated, they were able to get a PET scan. They started doing WADA testing to lateralize for memory and speech, and they did subdural EEG, and they could do mapping of function intraoperative and do video EEG as well. And then in the third phase, they started incorporating electrocorticography as an example. Now they did anterior temporal lobectomies, so the selective amygdala hippocamectomies, corpus callosotomies, and they just kept on developing that. And you can see in the first column is the first period, the second period is then that period after 2005 till 2017. Initially, they did in the first period, they did 65 patients in that first 6 years. And you can see that a lot of those patients did very, very good. They have patients with focal seizures that all were localized to the temporal lobe. And as we said, they did temporal lobectomies for that area specifically. And I'll show you now what the outcomes was. And in the second period, you see they now started going to extratemporal lobe epilepsy as well. But they got more evolved, they got experience, and they started doing PET scans as an example as well. The outcomes during the first period, you see that 33 patients had an Engel grade 1 outcome of that standard temporal lobectomies. That means no medication for the rest of your life. You are cured. 7 patients had the Engel 2 and 2 patients had the Engel 3. None were not helped. During the second period, you start to see that they had more patients and they started doing extra temporal lobe as well. And the outcomes kept on improving, even though they were pushing the boundaries. Time matters, and developing that skills is incredibly important. And this is just a summary of where these cysts were and the types of epilepsies that they treated. Remember, the first group was only temporal lobe epilepsy, big group there. And then they started expanding it to all the other types of causes of epilepsy. And it's a wonderful way to look at how a unit, specifically in a resource limiting center, develop their own practice and develop it. I'd like us to stop there, and I'd like to ask if the panelists can open their videos as well. Can I ask if there's any specific questions? I think there's quite a few things that we can talk about and topics that we can touch on and we can talk about specifically. So I'd love to hear your Dr. Baisa and Prof. Figan, and forgive me, I missed the other doctor's name in the beginning. But one of the things that I think we can talk a bit about is whether you think this is a safe approach. I must say I really like this that the group in Indonesia has done. And I would absolutely recommend that to any person starting out epilepsy surgery practice anywhere in the world. Start with the smaller, the definite cases. Start with the temporal lobe cases. Learn the anatomy, and then if there's a lesion and you correlate that with your EEG, I think you can keep on just progressing from there. Don't start off with these massive big cases from the start and then have poor outcomes, lose the neurologist's interest, lose patients and the hospital's buy-in into. You need to get a good bang for your buck, especially in the early time of any epilepsy surgery practice. But please, I'd love to see if there's any questions or what your thoughts are.
First of all, thank you very much, Nico. This is a great presentation, and it's really share your experience and the literature, how to set up an epilepsy program. This is great, and we have many examples and many papers published, and you really ended by showing one of the paper. I agree with you, which really I think it's one of the role model papers for the low income and mid income countries, and how to put up a very comprehensive program, which require, as you mentioned, many personnels, many diagnostic tools, referral centers for the disease, and how to acquire the neurosurgeon, train them to do the procedure, and ICU, and etc. My experience, I think, is the same as the Indonesian paper mentioned. And over the last 15 years, when I came from my training, one of the things that we did is, when we started our program and we put everybody together, is we have done probably the first 80 operation we have done, 75 were lesional temporal lobectomy and 5 corpus callosotomy. So this was done over 5 years. So you are 100% correct, and this is what we did exactly. We did not really go to the complex cases, and later on we learned more and more as we practice. And then nowadays, if you ask me how many temporal lobectomy you do, nearly 50% than before, and most of them, they are non-lesional. So in your epilepsy center, when you start, you're going to have the straightforward cases, and this is good to build up your experience, your whole team experience. And then later on, you're going to be a referral center. You're going to finish all the lesional cases, and you're going to have the complicated cases, non-lesional, where you really have to advance your care. I think one of the, there are many limitations still in a low and mid income. One of the important things is the advanced technology, like doing magnetoencephalography. If we have only one center in Saudi Arabia, we refer to them. Invasive monitoring, as you mentioned, you showed few cases. This is not an easy thing to do, and you have to build your experience with it. And we already have done this over the last 5 years. Neuromodulation, like either DBS or vagal nerve stimulation. This is something that you're going to end up needing these tools. In some cases where the patient is intractable, he's not good candidate for resection, you really have to have another option. Okay, and adding medication will not be optimal. So you have to move on for another neuromodulation, which is expensive. You need to have a very good coverage from the government. Each implant costs really more than 20 or 25,000 US dollar. So this is really an expensive implant. So I will stop here, and I would like to hear Professor Fegan and Dr. Najar and learn from their experience. How did they started, and what was the obstacle, and how can they really teach us and learn from them how they find this problem and solve it.
Well, hi, Dr. Saleh. Thank you very much. Well, firstly, Nico, thank you very much. That was just a fabulous talk. I think it's such an amazing perspective based on clearly many years of thinking about these issues in a resource-limited setting. This is not something you just get out of a textbook. The maturity and wisdom of the approach that you described. And I think I want to start by really acknowledging ILAE and the tremendous amount of work that's been done by the International League over the last few years in really trying to just educate healthcare workers about the role of surgery in epilepsy. Clearly, there's still a long way to go, but I think it's really fantastic that organized or medical organizations are really taking up the cudgels on behalf of this very effective treatment. I mean, all of us who've had the pleasure of doing epilepsy surgery, I think all of us consider it one of the real pinnacles of our careers to be able to take somebody who is suffering from epilepsy and make them seizure free is incredible. It's just an amazing experience to be able to do that. I want to maybe pick up on the sort of pediatric versus adult practice difference. And I think when Dr. Saleh spoke earlier about the starting off with a high preponderance of temporal lobectomies, I mean, presumably that would be in a sort of an adult population. And to a large extent, when you are establishing a practice, I think, Nico, you were very accurate in your description of the hesitance, and I think understandable hesitance of pediatricians and pediatric neurologists to refer patients for surgery kind of early on. And in a sense, you have to sort of get people's confidence by demonstrating that you can do the surgery effectively and safely. And I think in most places where there hasn't really been any practice of epilepsy surgery, there are going to be an awful lot of adults to begin with. I love the way you described the rejoicing in the plasticity of the brain in children, and that's our big privilege in pediatric neurosurgery. But I think to begin with, certainly there are going to be a lot more adults that are those obvious cases, and then recognizing that generally the pediatric cases are going to require a little bit more workup. But I guess the question I want to pose, and it's a question to which I don't think there is an answer, but I'd be interested to hear other people's thoughts, is for more than 30 years now, we've been talking about the treatment gap for epilepsy generally, but particularly for epilepsy surgery. And is there any data to suggest that we're actually achieving anything in closing that gap? I mean, it is impressive that there are more and more centers publishing experience from low and middle income countries, but is there data that suggests that in fact more patients are getting surgical treatment now for epilepsy than was the case 10 or 20 years ago? Is anyone aware of any such data? Are we winning?
That's a difficult question, and the practice going on, and this is even in a high volume centers in Europe and North America. There's a change of I would say the complex epilepsy cases, and where these cases are coming more difficult, and there's for some reason even in our practice we don't see the straightforward temporal lobectomy. We have a lot of temporal lobectomies. Some of them they have bilateral discharge, or as Nico mentioned, some of the cases where they require advanced monitoring. Some of them they're non-lesional. So we had an impression that, at some point we're going to have a drop of surgery for epilepsy. In fact, the drop in my practice did not happen, but it's even more because of more referral, and we're getting difficult cases where we're going to level 3 and level 4, where we have to do MEG, we have to do stereo EEG or intraoperative monitoring and recording for them. We have to do PET scan in all of them. So I think the trend has not changed, but maybe the complexity of cases in my practice has shifted a little bit. But and we have more cases for neuromodulation where at some point we have no answer for the patient, and at least we do something as a palliative for them, or maybe we have to can bring them back later on, and maybe we can get more answer from their investigation. But I think this is a very good question, and the data is not very clear, and no much people writing about this for some reason. But we hear it in all the conferences about the experience of most of the epilepsy center. I came across one paper by Mansouri. He's from Canada. He published an interesting meta-analysis where he collected all the outcome of epilepsy surgery from low and mid-income countries. And interesting, although most of the cases were temporal lobectomies, but so interesting, he compared it to the higher center of high income, and he found there is no much different in the outcome. So to start epilepsy surgery for a straightforward temporal lobectomy, I think you're going to have the same outcome at your center, but you really have to select your patient very well, as Dr. Miko presented, and he gave a sort of very gradual progression in practice. If Dr. Najar, do you have any input on this question also?
Yes, thank you, Professor, for the answer. Actually, there is no good answer after your answer. You are the expert in the Western region, and thank you very much for answering. So the most difficult part I feel, or I'm facing on a daily practice, is actually the how to define what is a low-income center. Because if you have a neuropsychologist, a neurotechnologist, a neurophysiologist, and a good EEG and a good neurologist, then you cannot apply this in a low-income country, because you basically have the same as in the best center in US or Canada. So this is the biggest question in my mind. So if you really do have these facilities, then you might be very close to the high centers in US and Canada or somewhere else in the world. So my question was actually to Dr. Enslin. So a new professor. So how you can get these resources in low-income countries? Of course, you're going to pay a lot to have a neuropsychologist and technicians and good EEG machines. And this is actually the main difficulty I see sometimes in low and middle-income countries in some places.
I think that's a very, very good point. And I think the important thing is that the psychologist and the social worker and the psychiatrist probably it's more related to that workup that needs to happen. It doesn't in essence need to be a neuropsychologist, but you need to make sure that your social worker, as an example, gets training at least at the center where there is a psychologist to at least help with the basic work. And I think that's how most lower income places do it. You double task people so that they do it.
Let me ask a question that I found in the Q&A box. The question was how to get access to learning invasive EEG monitoring, and I take it the person who asked probably he has at least some sort of background on epilepsy surgery, so he wants to advance into complex cases where they require invasive monitoring. So what's your advice, how to get an access to learning to a center, or learning how to set up an invasive monitoring setup? So this question to Nico, Ahmed, and Professor Regan as well. So please go ahead.
It seems, Professor, that Dr. Enslin has disconnected, but there are. So, according to my humble opinion and very small experience, so I think the best way to learn about invasive EEG is actually to first learn EEG. There are many online courses that you can get online for EEG, and when you learn EEG, then actually invasive EEG becomes a piece of cake. You just need to know where is the electrode, but it's basically the same EEG reading as non-invasive EEG in its essential aspect. But there are many online courses for EEG that they can go over 6 months or a year, or even like diplomas in EEG, and then we can like take some courses or some observership to send where like they do high volumes of invasive EEG, and really it becomes a piece of cake. But I think, according to my humble opinion, that the first step is actually knowing how to read EEG or how to understand EEG, and this was one of my questions or comments, that maybe a neurosurgeon in low or middle income countries need to know a little bit more about how to interpret EEG than neurosurgeon in high income countries, because most of the neurologists in high income countries are very good in EEGs, but maybe the neurologists in low and middle income countries have a little bit less experience with reading EEG. So the neurosurgeon has at least to know the basics to really be able to comment and understand what's going on in the patient's head. And I don't know what to think about it, but I really think that neurosurgeon in low and middle income country has to know a little bit about EEG principles.
I agree with you, Dr. Najar. I think, for those who have already training in electrophysiology for EEG, and they want to do it, and if they are from the neurology part, I think they have to be in a center where at least do higher volume of cases, where they're going to have some cases straightforward at the beginning, and then later on advanced cases of intercurrent monitoring. And this is how it's been done. One question is the collaboration with an international center. I think for some of the regions where epilepsy surgery, it's at its the beginning, it's very important to collaborate with either same country or nearby country or different continent centers where they have a collaboration, communication, where you can discuss cases with them through webinar. I think this is something, it adds a lot for the knowledge of the team in general and the surgeon specifically. And it's doable. Many surgeon, they can go for a fellowship or a short term or a longer term, like 1 year, into advanced center in Europe or North America, to be trained in epilepsy surgery, for example, and they can come back and start this link, the collaboration with their trained center. So this is something I would advise. It can help people to advance more in doing epilepsy surgery.
I think Dr. just joined.
I had to log on again. I'm sorry about that.
Yeah. So, Professor Figan, I mean, you have a really marvelous experience with pediatric surgery and particularly with the epilepsy. How did you find at the beginning of your career? What was the obstacles, and how did you get around it and advance the epilepsy to the current practice now? I know pediatric epilepsy center. I think your center is the only one in Africa, as according to the International League of Against Epilepsy, their criteria. There is a paper coming in epilepsy about this, and I read just quickly the abstract, and I know your center is the only one in Africa. So I'm sure you have done a very extensive workup to reach to this level. So what's your advice for the audience who are wanted to go and follow your footsteps?
So that's a really nice question to answer, because the answer is straightforward. It's having a neurologist who believes in epilepsy surgery. And I can say that based on my experience, both on the adult side and in pediatric practice. So when I was starting off my consultant career, we had a head of neurology at Refractory Hospital in Cape Town, Professor Eastman, who was extremely keen on epilepsy surgery. And he used to work up a lot of patients in the epilepsy clinic, looking for surgical candidates, and it's hard work. I think it's easy for neurosurgeons to bemoan the lack of workups being done, but it's a lot of work to do that. So I was really grateful in the early days of my career. Hi Nico, welcome back. Got your phone charged.
My sincere apologies. It's chaotic. I apologize for that.
I got booted out as well somehow. Anyway, so
we're definitely not from a first world developed country. We've got electricity problems.
So from on the adult side, for sure, having an adult neurologist in Professor Eastman, who was keen to do those workups, and if you don't have a neurologist who's going to be enthusiastic about finding the patients, then it's never going to happen. And I think the other, on the pediatric side, we were incredibly fortunate when Professor Joe Wilmshurst settled in Cape Town, and Joe had a real passion for not just for epilepsy, but for curing epilepsy and finding patients who could undergo surgery, and coupled with tremendous faith in her neurosurgeons. So we were very lucky. And then we also had really great support from neurologists around the country who've referred patients down to us. Dr. Scher in Johannesburg, for example, sent many patients down to be worked up in Cape Town and undergo surgery. And so I think that sort of regional network has been another very important factor. Nico certainly emphasized that you can't have lots of small centers all having a crack at doing the surgery. And I think for each country, trying to have one center that does focus on surgery for epilepsy is a very good start. I would imagine neurosurgery is very, very sophisticated in North Africa. So I would imagine that there's a lot of epilepsy surgery. I know in Morocco, my colleagues in Rabat often report on epilepsy surgery, certainly in adults. I would imagine doing children, there's some very good functional neurosurgeons in Algeria, and obviously Egypt is extremely strong in neurosurgery. So I would imagine that there are pediatric epilepsy surgical cases being done elsewhere in Africa, but in sub-Saharan Africa, I think at the moment there's very, very little else. And that's a huge opportunity. I think the biggest opportunity, I think, for ILAE is to try and develop surgery for epilepsy. And you know, as Nico said, a well-trained neurosurgeon understanding a few basic principles of epilepsy surgery, I think, is able to deliver a marvelous service. But that's got to be coupled with a neurologist who is enthusiastic to find the cases. So sorry, that's probably a longer answer than you wanted. And boil it down to one thing, and that's a neurologist who is going to help you find the cases and select appropriately.
If I may I add something to that, Prof? I think an incredibly thing, exactly that, but also mentorship. If you can link with a mentor in another area, in a bigger volume center, just to have someone, especially in the early years or days, to reflect decision making on ideal candidates, to still have contact. As an example, for Dr. Najar, to just have the ability for you to still communicate with the people in Toronto or the people in Montreal. That's worth so much more than its weight in gold, to have that network. Talking about networks again, but in epilepsy surgery, I think for all of us, I don't, independent of your advancement levels, just to have that ability to reflect off other surgeons and other epilepsy units is incredibly worthwhile.
Thank you very much, Professor. That's what was Professor Boubaïsa talking about when you were disconnected. So I was talking about the collaboration, especially with the centers we were trained in. So I am in good collaboration with Dr. Boutier from Montreal and Dr. Valiante from Toronto. So I always like ask them about their opinion, and it seems like it's going good.
Absolutely, and those are the relationships that we must keep on kindling, and we must keep on forming. And I think if we can use the network that the ILAE has already to match and to join people starting up these units all over the world, if we can start matching them with experienced centers, whether it is someone going there for a few weeks, I don't think one necessarily needs to do a 2-year formal epilepsy surgery fellowship in Montreal to be a good, safe epilepsy surgeon. But spending a few weeks in Montreal is incredibly valuable, or spending a few weeks with you and your unit, or a few weeks in Algeria, or a few weeks in Rabat, or a few weeks here with us maybe. Those are incredibly important. And then you have that link that you can always communicate. These days, WhatsApps, videos, Zoom, it has really opened up the world to us. One should never be isolated anymore. The definite problem is, like you mentioned, and forgive me, that's when my phone gave issues now, but is to cross that bridge of financial, the resources. There is a basic level, I think, that one should be able to have before you embark on epilepsy surgery. And that's why I think, for instance, the MRI versus only a CT, I think MRI is really, patients should ideally have an MRI always, and you should have EEG facilities. Otherwise, probably it's not something that one can do. So yes, bulking up on people, dual tasking people, so that if you have a social worker or a speech therapist that can do a bit of the neuropsychology as well, and in that way save money in resources, human resources. But definitely invest in getting mentors, invest in spending time somewhere, and you have to find a way to invest in imaging, and you have to find a way to invest in the electrical data, the EEG. Prof. Egan, I see you've got your hand up as well.
Nick, I just want to draw attention to a great question that's been posed in the chat by Amy Dolman, who you know. So Amy's posed a question whether problematic availability of anti-epileptic drugs in low-resource countries may play a role in decisions around epilepsy surgery. And I want to pick up on a statement that you made that I would agree with, although it's, I think, still quite provocative, that that even an individual who is well controlled medically, who has a lesion, perhaps could be a candidate for surgery. And in a country where the supply of anti-epileptic drugs is not necessarily that reliable, if you can cure the patient and liberate them from a lifetime of dependence on medication, that's a big victory, isn't it?
Absolutely, I agree with that. But you need to be very safe that surgery is going to go very, very well. And that's the case with every epilepsy surgery. There's no room for errors, and one has to be so careful. And that's why we all, worldwide, epilepsy surgery complication rates are among the lowest of any neurosurgical complication rate if you look at the whole spectrum. And it's because we all have the same sort of matter that we're made of when we're interested in this. We take such good care of our patients, and it's such difficult decisions to make that by the time we decide to operate, we pull that trigger, we really take a lot of care with every single step of the case, the pre-op, the during surgery, and the post-op care. And especially if you have a patient that is well controlled on epilepsy medication, sure, people are going to come gunning for you if things do go wrong in that patient and they're worse off. That sort of double loser scenario. Maybe you'll cause uncontrolled seizures with the complication that you have. So one has to be careful. Yeah. But drugs cost a lot. These epilepsy drugs, as soon as you go past the second tier of drugs, it's all these special imported drugs. I think it's like that for most places over the world. They become incredibly expensive. And then it's very quick to rather purchase an MRI scan for your unit than to have 10 or 20 patients on these incredibly expensive 5th, 6th, and 7th line agents.
I see there's another question as well about training in invasive EEG. Anyone have a comment on that?
I think it's a natural evolution. I think as soon as you start doing the low-hanging fruit cases with the temporal lobectomies and the colostomies, I think the next step in evolution must be to at least start forming an ability to have some form of invasive monitoring. And one should never underestimate basic subdural EEG grid still. I think it still has an incredibly big role. We don't all have to, we can't afford putting 20 stereo EEG grids into one patient. So if I do have a depth electrode, I use it specifically to answer a specific question every now and then. But our bulk workhorse, as you know, is subdural EEGs. And still one can do a lot of epilepsy surgery just with scalp EEG, but it's the longer term telemetry. I think that's where the magic happens. I don't think single shot scalp EEGs are very, very helpful for as soon as you start crossing to that second tier of epilepsy patients. But it would be great to hear what Dr. Najar and Dr. Bayesha thinks.
Yeah, I agree. I think implementing invasive monitoring, it's something you have to do it down the road when you start epilepsy surgery. When we did, actually in our center, started 15 years ago, we went invasive simply with ECOG, intraoperative EEG, cortical, just mapping and recording of some cases. And then later on, and we moved into the subdural monitoring through craniotomy or bare hole strips, unilateral or bilateral. And then now we're moving to stereo EEG. So this is the trend. And I don't think you're going to jump quickly from doing resection into stereo EEG. I think it's a matter of training and education and learning. You have to give it time. You just have to proceed like everybody else did in their training and then practice. So as Nico elaborated, I think it's going to come with time. You're going to finish the straightforward cases. You're going to have cases that require invasive monitoring, maybe advanced imaging study like PET or MEG scans, and then you're going to learn with it and start doing it. Yeah. One point I think you mentioned in one of your slides, Nico, I like it, which is patient education I think patient education, getting into the media from neurology and neurosurgery, it's a very important. Now the media is open in Twitter, Facebook, and patients and people, they react and they communicate and interact a lot. And this is where you're going to get more support from the patients and to the government. You know, if you want to buy something expensive, I think in low and mid-income countries, it's not like, I mean, money is very important, but it's available. It's just been shifted somewhere else because of the importance. I think if epilepsy surgery in a country that everybody make it something important, where you have a lot of cases, you have a lot of population, and you have the manpower and you have the facilities, and what you ask for is not, you know, like billions. It's, it does not be more than maybe 3 to 4 million US dollar, which is, you know, affordable. I think this is something that everybody has to start doing, and this is what we have done in our early practice when we needed to acquire more sophisticated equipment, and we have to go in an area to outreach to get patient, and we have to show. We presented our cases to the administration, and one of the newspaper helped it, and then helps in showing these cases, and then we got money specific for epilepsy surgery, and we bought a few things in the beginning, and now things are coming. Whenever we ask for something, it comes easily because we have a very good credential with them, and we are credible in what we say now nowadays. So this is something that I think we should not ignore this part in where you can get support, which is, I call it easy. It's an easy support, and you have to work very well with your colleagues in the hospital and the media. Try to elaborate more about epilepsy surgery.
Thank you, Dr. Baisa. That's incredibly inspiring, the story of how you've developed epilepsy surgery over the years in the kingdom. That's really incredible. Be very helpful to write that up and document it for others to learn from. I see there are 2 other questions here from Dr. Saleh asking about experience with corpus calostomy for generalized epilepsy apart from drop attacks. In low-income countries, neuromodulation not being available. And then there's a question about, and I think, Nico, you touched on this, the role of epilepsy surgery in genetic syndromes, apart from palliative operations. Do you want to comment on either of those?
I think it's important to look at that. The important thing in terms of the genetic problem is that, yes, we do know that if patients with genetic causes of epilepsy have these sort of channelopathies, so there's a widespread problem often, but it mostly, or very often, it still is regional. It's not necessarily a whole brain abnormality. And I think if the semiology, and with definite, for year, I think one needs to use every modality that you can get. But if you can localize the abnormality, I think there is still a role. You just need to have a good focality to the abnormality. So using in more invasive EEG probably to be 100% certain where your focus is. Using imaging if you have ability for PET, the sort of metabolic type of scanning like PET. I think there is many units who do think that genetic epilepsies and syndromic epilepsies are also still candidates for surgery. It's all about the locality of it. If you have a focal nature of it, then I think it's independent of what the cause of it is. whether it's tuberous sclerosis with multiple lesions. If you know that the seizure comes from a single lesion, I think resecting that single lesion area is still good. It might be that in 10 years in tuberous sclerosis that one of the other lesions gets the problem, but it was 10 years that the patient had better epilepsy control or complete epilepsy control. So I think, Prof, in general, the big units would see any cause of epilepsy as almost irrelevant, and that it's about where that focus is. If I can identify it and you can localize it, then it is resectable. I didn't, forgive me, the first question, I now forgot what you asked, the first part of the question.
It's, can you tell us your experience with corpus callosum with generalized epilepsy apart from drop attacks?
Thank you. I think in general, the safe, definite slap bang indication for colostomy is the atonic seizures, the drop attacks. But definitely, I think there is a role, a palliative role specifically for corpus callosotomies. In patients that has diffuse, widespread epilepsy, that's refractory, there's no locality to it, you can't focus, you can't resect or disconnect that part of the brain. There's quick generalization. By doing a colostomy and preventing secondary lateralization or secondary generalization of a seizure, I think it definitely has a big role. It's important, however, to weigh up that role against what the neuromodulation options are, because they also fall in that same sort of palliative group. And there is a lot of studies that does show that the colostomy still has better quality of life outcomes compared to vagal nerve stimulation, as an example. But I do think in our setting, to get a vagal nerve stimulator, you probably you run out of kidneys at some point because of the bits of kidney that you have to sell of your own body to afford it. It's incredibly expensive. A vagal nerve stimulation today in South Africa is almost double the cost of deep brain stimulation. So it has become disproportionately expensive. So if I have a patient that really has these troublesome 15 seizures per minute, the child has a low level of consciousness, sleepy the whole time, doing a colostomy and being able to get them off a lot of the medication is incredible for the quality of life in that specific patient. So I do think there is a role for colostomy outside of drop attacks as well. One just needs to make sure that you weigh up the benefits and the risks again with it. If there is neuromodulatory options available and affordable, then they probably carry less risk than a colostomy, but a well-timed, safely performed colostomy makes a massive difference for a child with these severely debilitating epilepsy syndromes. But I must say, for me, it's a last resort, the end result. I don't know, Dr. Najar, if you would agree with that.
Thank you very much, Dr. Eslin. Of course, yes, I would really agree with that. And nowadays, the only issue is these patients, as you mentioned, they are really severely debilitated with severe epilepsy. So the biggest question comes to whether you do like just anterior 2/3 or you do complete colostomy. And of course, if you do complete colostomy, they will end up sometimes having severe cognitive issues. But these most of the time are almost debilitated, not moving around. They are bedridden. But if you, sometimes, according to my very humble experience with one patient or so that I've seen, not do it myself, like they just stopping having seizures, the parents were so happy that their child didn't have any seizure last night. So I really would agree. And you're right, VNS is very, very expensive. And with the new trend that I don't know if Professor Fegan agrees, that the new trend among neurologists that even with the straightforward syndromes nowadays like Dravet, Giovanna's or stuff like that, still they would like to see EMU for the children before going to VNS. And having EMU like in low middle income countries would like add 10 more months to the child having seizures. So just the waiting list to have an EMU in low middle income countries can go up to a year or 2 years. So I really agree, and thank you very much for the comments.
Prof, one of the things that I brought up and that I'd like to maybe ask your thoughts. I don't know if you maybe have discussed it in the time that I was offline, but regarding imaging, the question of MRI scans, we know that in sub-Saharan Africa there are many countries who do not have an MRI scan. Is it a fair remark from me to say that if you don't have the ability to have at least one workup MRI scan in a patient for epilepsy surgery, that probably that patient should then rather be referred somewhere where it can be done? I know it excludes big portions of the world, but I do think that outside of like that one CT that I showed where there's a clear cleft, like a schizencephaly or something like that in the patient, I think you do a disservice to both yourself and the patient in operating without an MRI scan. But I'd love to see, because it is a restrictive remark, I think.
Yeah, I think I would. Sorry, Professor Began. Go ahead, Professor Began. Go ahead.
No, please, Professor Baisa. Do you want to carry on, and then I'll
yeah, I'll make a short comment, and I agree. I think MRI it's a gold standard test for a patient with intractable epilepsy. I think we need a lot of information, and we have epilepsy protocol which include flare studies, we include inversion recovery, where you can see the cortices, you can see the structure of the brain, and you really we started with 1.5 Tesla. Now we have 3 Tesla. We see more small structural lesion with MRI, and this is something that increased and made us really naming some of these patients with non-lesion into lesional. And we have some case of temporal lobectomy. When we re-image them with our new scan, we really found that lesion, and eventually we went for surgery. So I agree. I think MRI is a very important tool, and CT scan it's a good screening. It might be very good for very obvious temporal tumor like ganglioglioma. It might be fine to go ahead, but I would, in my practice, I would still go for a detailed MRI. I would agree with that. Yeah.
So, Nico, there are 2 parts to my answer to that question. So the first is that there was a paper from Mbali in Uganda about, which I think you've seen, about maybe 15 years ago, reporting 10 patients that underwent temporal lobectomy. They had about 50 adults, as I recall, that they worked up for seizure surgery, and they only had a CT scanner. And just on the basis of reformatted coronal scans combined with EEG. The EEGs were done in Uganda, but the EEG interpretation happened in the US. On the basis of the coronal reformatted CT scans and the EEG, they did 10 temporal lobectomies. I think there were 7 patients that had Engel class 1 or 2 outcomes. So it was a proof of concept that if you select patients properly and you don't have access to MRI, it may be that CT could work. And I guess that would be the sum total of my answer until a few months ago when I saw the hyperfine MRI scanner. And I do think, and I don't know how widespread this is yet, but I think it's still very much a research tool, but this very low field portable MRI system, which certainly showed promise of being inexpensive and readily available. Whether it will remain inexpensive is a different story, I guess. But if it is possible to have low field portable MRI available in low middle income countries that can't afford 1.5T, let alone 3T MRI scanners, that's going to be paradigm changing, and that will really open the door for developing epilepsy surgery, because as Professor Baisa says, it really is the gold standard, and it's problematic to compromise, but there simply are countries at the moment that just don't have access to MRI, and I would hope that low field portable MRI is going to be the answer, provided it's a cost effective. Certainly the image quality, I think, is good enough. You may not find those small, difficult to find dysplastic lesions, but you'll certainly find the significant anatomical abnormalities. Have you, Saleh, have you had an opportunity to see this portable low field MRI scanner?
Yeah, and I think I've seen it in conferences, and I think many years ago they brought one portable one. It meant to be for intraoperative MRI, which is movable. It's not really fixed to the wall or to the floor, which you can move it around, and it's small. I like it, but the resolution definitely better than CT scan. So in a places where you cannot afford having really a big magnet, I think this is something to go. And it's mobile. It's you can move it from place to another place in the hospital, or even out to another hospital if you have to. If you happen to have a lot of cases in one place, and I think it's good. I think it's 0.5 Tesla, most of it, but I was amazed by the imaging. I thought it's really poor image quality, but it was not bad actually. I think it's a good screening tool, better than standard CT scan. Yeah.
Thank you. Just maybe a question to participants. If any of you have more questions, maybe put them in the chat and we can address them. Okay. So there's a question from Dr. Tabrizi, who says he has a 25-year-old patient who couldn't undergo an MRI because of a pacemaker and has refractory focal seizures with impaired awareness and a normal CT scan. Is surgery recommended for her? That is a great question.
No, I think it fits in very nicely with what you said as well, and in the past few minutes, and that if this patient has, it's important just that this patient needs very, very careful EEG evaluation. So if you have focality proven on scalp EEG, and you have the ability to place invasive monitors thereafter as well, and you keep on coming to the same point, then definitely, if the patient, for instance, has temporal lobe focality, then a temporal lobectomy for that patient, but only after the EEG shows it, would be good for her. The problem is if it's not in the temporal area, if you have these sort of parietal, perirolandic type of seizures, then it becomes incredibly difficult to do it based solely on a CT scan. And I think then it would be difficult. So it would be important to know for that patient what the semiology of seizures is. Again, coming back to the workup of epilepsy, what the semiology, what your clinical finding shows, and what the scalp EEG shows. If it continues to prove to a same point, then definitely I think the further workup can be done. But I think it's important to have that further information.
And Professor Insulin, I don't know what type of cardiac pacemaker, but nowadays sometimes if the cardiology is like at ease and he can manage the pacemaker, really pacemakers are becoming safer to under MRI. So it really needs to check with the cardiologist if the pacemaker is really safe to go under MRI machine. And sometimes there are some maneuvers around it, either to stop it temporarily or even under GA, the MRI under general anesthesia. So that would be some options if really it's necessary to do MRI.
Thank you. That's very valuable.
I see it's nearly 9 o'clock, and I think we just had till 9 o'clock. If anyone wants to make some wrap-up comments.
Yeah, well, it's time flies. It's amazing. It's a great presentation, Dr. Insulin, and superb comment and discussion by Professor Vegan and Dr. Najar. For those who attended the session, thank you very, very much for your time. And that was a great session, and I hope that would add to your practice in developing epilepsy surgery at your region, in your hospital and your country. And I hope in the future we're going to have more advanced presentation. That by that time, hopefully, you're advancing with your epilepsy surgery and epilepsy program, hopefully. And I thank the ILAE for the webinar setup, and I thank you very much, Nico and Professor Vegan and Dr. Najar again. And I'm happy to moderate the session.
Thank you so much.
Thank you very much, Professor.
Thank you.
Thank you.
Have a great evening. Thank you, everyone.
It was nice meeting you. A very honor.
Thank you. Lovely meeting you, Ahmed.
Wonderful
Thank
to share the
you.
platform with you. Thank you.
Thank you.
Yeah. Thank you so much.
Thank you.
Thank you, Dr. Najar. Thank you, Dr. Professor Baisa. Good
Thank
night.
you, Prof. Paisa. Bye-bye.
Thank you. See you. Thank you.